Welcome everyone to today's CIRA talk, recommending physical activity in the context of HIV and substance use. So while we're waiting for people to join in, I'm going to do a couple of introduction slides. If you are new to CIRA, we are an IMH, a National Institute of Mental Health funded research center at the Yale School of Public Health. And we would recommend you to visit our website, cira.yale.edu, where you can sign up for the CIRA e-bulletin, which is our biweekly newsletter with our website, and our e-bulletin has a lot of information about events, other opportunities such as pilot grants, fellowship programs, implementation science resources. And I would encourage you to visit and make connection with us. And in terms of calendar of events, so in addition to today's talk, there's another talk this coming Friday that would be the last event that we will hold this year, and it's part of our CIRA qualitative research discussion group. I will post the links into the chat shortly, and would welcome anyone who's interested in joining to participate in this upcoming talk on Friday. So today's talk, we will start with a brief introduction to the speaker and discussant, and it will be followed by a presentation by the speaker and a discussion, and also to open up a Q&A session with the audience. And I would invite everyone to please join the conversation, submit questions, thoughts, and comments using the chat function. And we will try to respond to all the questions as they come in. But if we run out of time, I will save the chat file and send it to the presenter so we can follow up on a later date. And with that, I would like to introduce our moderator today, Dr. Jennifer Edelman, who's Associate Professor at the School of Medicine and the School of Public Health. And she is also the Director of CIRA's Clinical and Health Services Research Core. Jen?
Thank you, Dini, and thank you, Pete, for organizing this. And thrilled to welcome Dr. Pescatello to speak with us today. She's a distinguished professor of kinesiology at the University of Connecticut at Storrs, and has been there, I think you just told us, since 1998, right up the road. Her research focuses on using exercise prescription to optimize health benefits, using exercise combined with behavioral strategies to reduce substance use, and genetic and clinical determinants of the response of health-related phenotypes to exercise. She's helped lead clinical guidelines. She is associate editor of the Guidelines for Exercise Testing and Prescription, the 8th edition, and has been an international leader in this space. And we're really just thrilled to be able to learn from her today. So thank you for joining us. And Dr. Declan Barry will be our discussant. He is a clinical psychologist here at Yale School of Medicine in the Department of Psychiatry, leads the research at ACT, and has done a tremendous amount of work in the interface of pain and substance use, including with exercise-based interventions. And so really looking forward to this discussion. Thank you. Dr. Pescatello, I'll turn it over to you now.
Okay, great. Just give me a second. I'm sharing my screen. Just want to make sure everything's in working order. All set? Great. You can see everything. Well, okay, terrific. In going to your website and some of the communications we had trying to plan me coming today, I have been told that a focus of CIRA is the application of physical activity to improve cardiovascular health outcomes in people living with AIDS and substance use. And I would like to take this opportunity to thank both Dini and Jen for inviting me on a topic I love to speak about. So thank you. In this slide, you see Gamble Pavilion, and as Jen said, we're right up the road. And that is where my department's teaching and research laboratories are located. but also inside Gamble Pavilion, it is the home of the Yukon Husky basketball teams. And I must say, we started our season with unbelievable excitement about both teams. And for those of you that follow Yukon basketball, and I know there's many in the state, we've had a few setbacks, actually major setbacks due to injury, but it seems at least mentally we're on the road to recovery until we get some of these key players back, and we're still hoping we can be competitive come tournament time. But you can see it's quite an exciting place if you've never been. And these other two pictures you see here, Tim was a kinesiology graduate student, and studies that I will be sharing with you today are my collaborations with Dr. Nancy Petrie from Yukon Health. And we did a series of studies in the mid 2000s, and this is one of them in Hartford, Connecticut, where Tim is overseeing an exercise session by one of our study participants, and the participants in this study had HIV and substance use, and it was a community-based outpatient setting. And we were there for about 4 years, and I'll tell you in a bit later in my presentation about some of these studies. And at this time, I would also like to acknowledge my colleague and discussant, Dr. Declan Berry, and we're very excited about what we're about to embark on with a recently funded NIH study that we have given the acronym IMPOWER, and it involves patients on medication for opioid disorder, and we are examining the influence of a stepped up care integrated intervention that includes exercise on these health outcomes and others. So I guess Declan will be moderating our discussion when I finish today. So Jen mentioned the American College of Sports Medicine guidelines for exercise testing and prescription. And I am going to share in the next couple slides some resources I am going to be referring to on numerous occasions during my talk today that you may want to purchase for your library, because I've heard, again, there's a real interest in using exercise with this clinical population. And this is the most recent edition. It's the 11th edition. It is the gold standard in the world for anyone conducting exercise testing and exercise programs. To show you its impact, it has been translated into 5 languages. So I would highly recommend this book. It's not very expensive. I checked on Amazon a couple days ago, and it sells for, like, I don't know why they do this, but $30.73. And you can have it in a couple days. The other resource I'd like to share with you are the 2018 Physical Activity Guidelines Advisory Committee scientific report you see here. And I was fortunate enough to be one of 17 members of this advisory committee. And we did a comprehensive state-of-the-art review on physical activity and its impact on a variety of health outcomes in clinical populations. It's over an 800-page document that can be downloaded free from this website. And I would highly encourage you to get this for your library. The one thing, my slides, Dini is going to be sharing the PDFs, and these links will be active. So from my slides that will be shared, you can download these resources. And this scientific report provided the scientific foundation for the second edition of the Physical Activity Guidelines for Americans, which is the policy document. And this document too can be downloaded free of charge, and it's about 150 pages. Now, the American College of Sports Medicine, which I should tell you is the premier sports medicine organization in the world, took 15 topics from the scientific report and made them into ACSM pronouncements. And these are scientific statements on this variety of topics you see here, those particularly relevant to people living with HIV. I highlighted here for you, and you can see there's some using high intensity interval training for cardiometabolic disease prevention. There's an excellent one on sedentary behavior, weight gain, cardiovascular mortality and cardiovascular disease. And one I headed up was one on hypertension. And the good news is you do not even have to be a member of the American College of Sports Medicine. You can use this link and download every single one of these PDFs free of charge. So I wanted to share that with you. So in terms of how my talk is going to be organized, I will start an overview with you, some basic definitions and concepts in exercise prescription. We will then discuss an exercise prescription that fits, and I'll tell you what that means in a minute, for people living with HIV and substance use. And then we will move on to deliberate special considerations in exercise prescription with a cardiovascular emphasis for this clinical population. So people use these terms as though they're synonyms, and they're not. And for this reason, I felt it was important to go over these basic definitions, because depending on if your emphasis is physical activity or exercise, the study designs vary, as do the health outcomes you could be measuring. And so physical activity is a behavior. It's bodily movement produced by the contraction of the skeletal muscles that results in increases in caloric expenditure. Exercise is a subset of physical activity that doesn't sound like as much fun. It's planned, it's structured, it's repetitive, bodily movement done to improve or maintain one or more components of physical fitness. In other words, there's some work involved. And speaking of physical fitness is a set of attributes or characteristics that we strive for to achieve that relates to our ability to exercise. And I will tell you in the presentation this afternoon, our focus is not on physical fitness, it is on physical activity and exercise. And the reason for that is, now we're getting into, we discussed basic definitions, and now let's get into some basic premises and concepts of exercise prescription. The quantity of exercise needed to reduce disease risk, or on the positive note, improve health, is considerably less than that needed to develop and maintain high levels of physical fitness. And this is an excellent figure. It's from the scientific report that I shared with you, and it illustrates this concept. And let me orient you to this graph. On the y-axis, you have the risk of all-cause mortality. The shape of this curve, this could easily be a graph of the risk of cardiovascular disease mortality. On the x-axis, you have a measure of physical activity volume, and that is met hours per week of moderate to vigorous intensity physical activity. And let's go to the curve now. You can see that engaging in no exercise, which is 0 met hours per week, and just moving to about 2 mets per week, which is equivalent to a total of 40 minutes of moderate intensity physical activity per week, or 7 minutes a day. You see the greatest reduction in risk from getting out of the chair. As you increase your volume of moderate to vigorous intensity physical activity, you see again that the risk continues to decline. And this region here, which is a little bit over 7 met hours per week to a little bit over 15 met hours per week, is the current recommendation for the general American population of 150 to 300 minutes per week of moderate intensity physical activity. You would divide this number by 2 for vigorous physical activity. And you do see that once you get on the upper end of the recommendation, there is a point of diminishing return, and the reductions in risk do level off somewhat. But again, a great figure. This is also taken from the scientific report I shared with you, and we affectionately call this, after 2 years of work, the heat map. And what the heat map is, you can see, is the relationship of moderate to vigorous physical activity to sitting time, and then depending on the color coding, which I'll get at in a minute, the risk of all-cause mortality, but it could also be the risk of cardiovascular disease mortality, because the shape of the curves are very similar. Looking at, again, the y-axis. Down here, you sit the least. Up here, you sit the most. Looking at the x-axis, you engage in no moderate to vigorous physical activity. And as you move along, this person would be engaging in the highest amount of moderate to vigorous physical activity. The red shading indicates greatest risk. The yellow to orange, risk begins decreasing. So this could be moderate risk. And then if you're in the green, which one of my students calls evergreen, you have the lowest risk. So let's go up to the person sitting here. And I'm going to ask you a question. I typically do this when I speak live. I give people quizzes. I'll give you a true or false. And obviously, you can just think about what your answer would be. True or false, the average American sits 8 hours per day. True or false? The answer is false. Do you know how many hours a day we sit? Depending, I saw the verbalization, depending on the source you use, it's somewhere between 12 to 14 hours per day. So most Americans are very high sitters. And look at the amount of moderate to vigorous physical activity you would have to do to negate the risk of high volumes of sitting. It's a lot, and more than most of us would do. So on a more positive note, if you don't sit all that much, by just doing, getting out of the chair, walking a 30-minute mile, you can see you begin to reduce your risk, and it turns orange to yellow. And this is important because it states that lighter intensity exercises accumulate and matter and can reduce your risk. However, the person with the least amount of risk is that person engaging in and meeting the recommendations I just shared with you of 150 to 300 minutes per week of moderate to vigorous physical activity. So in other words, all movement counts and it adds up. As one of my students has said in her master's thesis, move as much as possible on as many days of the week as possible to accumulate as much evergreen as you can. I love this slide. It was taken from a presentation I did with 2 of the advisory committee members at the New England American College of Sports Medicine a couple years ago. And these are the disease prevention benefits from regular, moderate to vigorous physical activity for the 10 leading causes of death, the 10 most prevalent chronic conditions, and the 10 most expensive medical conditions. All those colored in orange directly relate to physical activity. And what I've done for the talk today is I have italicized those particularly relevant to people living with age and substance abuse. And so when you look at the 10 leading causes of death, you can see they reduce the risk of death from heart disease, cancer, stroke, and diabetes. When you look at the 10 most prevalent chronic conditions, again, reduces the risk of acquiring hypertension, hyperlipidemia, mood disorders, diabetes, anxiety disorders, and coronary artery disease. And for the 10 most expensive medical conditions, at the top of the list are heart conditions, cancer, mental health disorders, hypertension, type 2 diabetes. So clearly, Physical activity is the best buy for our health, and it comes as a great package with very minimal side effects. So we've just overviewed basic definitions and concepts, and now I would like to move on to our discussion of an exercise prescription that fits people living with HIV and substance use. So what is an exercise prescription? It's a process whereby the recommended amount of physical activity or exercise is designed in a systematic and individualized manner in terms of the FITT principle. And I am proud to say that it was in the, I always get the numbers confused now, the 9th edition of the ACSM guidelines for exercise testing and prescription, for which I was the senior editor. That is when the FITT principle was established, and it's used to frame now all the recommendations from the American College of Sports Medicine, as well as other professional societies throughout the world. And what FITT stands for is frequency, how often, intensity, how hard, time, duration, or how long, and type, modality, or what kind. So when we speak of the T or type in the FITT principle, there's 4 types of exercise we will discuss as we move on. The first is aerobic or cardiorespiratory endurance. And again, it involves moving the major muscle groups continuously, repetitively. And again, if we're focusing on exercise, a purpose is to maintain or improve cardiorespiratory fitness. Resistance exercise focuses on 3 components of muscle fitness: muscular strength, how much resistance can be moved; muscular endurance, how many times or for how long resistance can be moved; or power, how fast the resistance can be moved. Flexibility, we think of stretching around a joint. And then neuromotor exercise, I will tell you, is an emerging exercise for its, as people get to know more about neuromotor exercise, it has a variety of health benefits we'll be talking about as we continue with my presentation today. And neuromotor exercise would perturb our sense of balance and work to also improve our agility, gait, and coordination. And the woman you see dancing here is a great example of neuromotor exercise, as is yoga and Pilates and Tai Chi. So this is, and actually this is taken from the 10th edition of the American College of Sports Medicine Guidelines for Exercise Testing and Prescription, which is what this abbreviation stands for. This is the current ACSM Fit Recommendation for people living with HIV. I'm not going to read through all the specifics for you, but highlight a couple. You can see aerobic is recommended 3 to 5 days per week. We start at a light intensity, progress to moderate, start with short bouts, progress, trying to again achieve the physical activity guidelines for Americans, which would be 30 to 60 minutes per day. And then modalities can vary. I'm not exactly sure why they put osteopenia and osteoporosis under the aerobic column. Again, this is a side effect of art, and we have to be cognizant of bone health. And the best exercise there is to maintain bone health is resistance exercise. So I would have put it under this column. And again, resistance exercise is 2 to 3 days per week. Start light, progress to moderate. And again, you can see a variety of equipment can be used. These are the recommendations for flexibility, which I can tell you are no different than the recommendations for healthy adults. And notice what column is missing. And I'm not exactly sure why that was done. In the edition that I oversaw, we had a 4th column, and it was neuromotor. And again, this recommendation is very consistent with the recommendation for healthy adults, but add up the amount of time we're telling people to do when you look at aerobic, resistance, flexibility, and neuromotor. And it's a lot of exercise to ask people to do. And we're going to come back to that. So surprisingly, there are little data available. We need to learn so much more in terms of a specific FITT exercise prescription for this population. So what we then do is resort to the guidelines for Americans, which you see here. And again, it's 150 minutes per week of moderate intensity aerobic, or you divide it in half for vigorous, or a combination of the two, and 2 days of muscle strengthening physical activity per week. And we also say emphasize cardiovascular health. But inherent in these recommendations, there is no emphasis for cardiovascular health. And we will get there in a moment when we start talking about special considerations. So again, this is the goal we strive for people living with AIDS and substance abuse. Whether this is realistic or not, I'm sure you have your opinions, and it's still a lot of exercise to be doing. So probably the most complex component of FITT to prescribe is intensity, because it also carries with it risk if it's too vigorous. So in the lab, we speak of oxygen consumption reserve, heart rate reserve, but in the field, these aren't really practical. And here you see the various exercise intensities ranging from very light to near maximal to maximal. Many of you, I'm sure, are familiar with the 0 to peak or percent heart rate max way of calculating intensity. And that's 220 minus your age, taking a percent. I'm sure many of you have determined exercise intensity this way. Another method in the field is the Borg rating of perceived exertion on a 6 to 20 scale. And again, you can see for the various exercise intensities, what the RPE rating of perceived exertion would be. So this is a great table and resource. And again, it comes from the American College of Sports Medicine guidelines. Now, with regard to the 0 to peak method and using heart rate max and this formula, the 220 minus your age, which we were all taught, I was taught, as time has gone on, there are better formulas to use that correlate more closely to the gold standard, which is maximal oxygen consumption. And so what I've done for you is box these here. You could use either because there's really not much difference in the determination of heart rate max. But I would suggest using these formulas than the old standard of 220 minus your age. I like the talk test. Very simple to use in the field. And let's read along here. What would correspond to light intensity with the talk test? Well, it's a level of physical exertion. It slightly increases your heart rate and breathing. You can talk and you can sing. And I give you some examples of light intensity exercise that would correlate with this description. Moderate intensity would be a level of physical exertion that does cause increases in heart rate and breathing, but you still can talk, but you can't sing. And a brisk walk would be an example of that. And you also see the corresponding rating of perceived exertion on that Borg scale I shared with you earlier. If you engage in vigorous intensity, there's substantial and very noticeable increases in heart rate and breathing where you can't talk. And obviously running and various vigorous weight training. And again, I like the talk test because it is practical. Plus, you can see what your patients are doing as well. So, unfortunately, over 70% of the people living with HIV do not meet these recommendations. Exercise adherence is a major problem, and it's a major confounding in the results of studies, as we'll discuss momentarily. The other issue, and there is no FITT exercise prescription for substance abuse, none. So that leaves me with the question, what am I supposed to talk about now? Well, the good news I have for you, there's plenty for me to talk about, because if you remember that emphasis on cardiovascular disease, I have a lot to share with you on how you can tailor and adapt exercise prescriptions for this clinical population. So I'd like to take a moment now and just very, very briefly overview for you the series of studies I did with Dr. Nancy Petrie and her colleagues, Dr. Weinstock and Dr. Alessi, and there were others. And I'll start by, oh, and there's Tim again. This is one of our studies with Dr. Petrie. And I'll focus on the 2014 study by Weinstock was a pilot study. So I'd like to start by focusing on our 2016 publication. And that was done on college students at UConn. They were heavy drinkers. And again, our goal was to achieve the physical activity guidelines for Americans. The 2020 Weinstock study was actually a study. It was a 16-week intervention where we involved contingency management, which was Dr. Petrie's. She put contingency management on the map. We used motivational interviewing and physical activity among 66 sedentary adults that were diagnosed for alcohol abuse and dependence, and they weren't receiving treatment. And then the Alessi study you see here was a 16-week intervention where we used contingency management and physical activity among 120 patients that were 18 to 65 years of age, and they did have a diagnosis of cocaine, marijuana, or opioid use. They were also enrolled in a community outpatient program and received standard intensive outpatient services. So that just overviews for you briefly what these studies were about. In all of our studies, again, because I told you there's really no evidence-based FITT exercise prescription for people with substance abuse, we try to achieve the physical activity guidelines for Americans. But we did add encouragement, think of the heat map, of physical activities around the house and doing chores and with leisure. And we also encourage planned short bouts of 10 minutes of exercising to cope with cravings in these studies. And I will tell you, on average, the averages by the end of these studies, it would appear that the physical activity guidelines for Americans were met in terms of the frequency of exercise on average. However, when you look at the individual response, about half the subject population met them and half did not. So again, exercise adherence is clearly an issue that confounds the results of these studies. And so the real key question to be answered, for which I will tell you needs a lot more work to come to definitive conclusions, is what FITT exercise prescription or exercise dose is needed for therapeutic benefit. And our studies and others have shown that exercise and physical activity indeed improve mental and physical health outcomes in this patient population. And here you see a list of outcomes I've compiled from the literature that focus on physical activity, but also you can see various health outcomes such as negative emotional states and cardiometabolic and skeletal health. What about substance abuse? Again, favorable findings in the literature that clearly exercise and physical activity are associated with improvements in substance abuse outcomes, such as reduced substance use and related behavior and problems. This is a little bit controversial in the literature, but our studies and others did show that the substance use outcomes weren't directly related to those changes in physical activity I shared with you that we saw. Is this all that bad? Well, no, because of the many health benefits I've showed you that physical activity can have on cardiovascular health. But I do believe that some of the reason there's controversy in the literature is the confounding effect of exercise adherence and the lack of rigor of some study designs. And this is why the work you're doing and why the work I'm about to embark on with Dr. Berry and colleagues is going to become so important, because the verdict is not out, and truly establishing what is needed for therapeutic benefit needs much more investigation. So let's move on to special considerations in exercise prescription, particularly relevant to heart health, which I know is an area of interest and emphasis for CIRA. So let's go back to the basics. These are just some basics in exercise prescription, in that initially you need to screen for comorbidities, which I know are highly prevalent in this population. Medication is a theme we're going to talk about throughout the end of my presentation, actually. And at the top of the list would be ART, because of its cardiometabolic health side effects that include hypertension, dyslipidemia, abnormal abdominal fat distribution, prediabetes, diabetes, as well as muscle wasting and weakness, and osteopenia and osteoporosis. So if the chronic disease, if a population presents to you with multiple comorbidities, the key question becomes, what do you focus on? And it's a major point of confusion for students that take coursework with me. And so, first of all, if the chronic condition is limiting, physically limiting, then you would perform physical activity as tolerated to avoid being sedentary. Let's go back to the curve I showed you. Where do you get the biggest reduction in risk? From getting out of the chair and exercising just 40 minutes a week or 7 minutes a day. This is an important rule of thumb, that you would deliberate individualing the FITT exercise prescription for 3 conditions. We already stated one, the chronic disease or condition that is most limiting, which often could be HIV, puts the person at greatest risk, cardiovascular risk, which could be hypertension, and or encompasses other chronic diseases or conditions. And what we mean by that is the FITT for a given chronic disease could actually be applicable to another chronic disease because they overlap. It's important to note that low to moderate intensity exercise will not suppress immune function. So that should not be a reason for not exercising in this population. But it's not just unique to people living with HIV or substance use. If there are acute affections, you would postpone exercise until the person is again healthy. A varied clinical presentation requires a flexible approach, and you clearly have to adjust the FITT exercise prescription, as we just said, on current health status and also modifications for age. This has emerged in recent years, and it wasn't a point of emphasis in the studies I did with Dr. Petrie. It's biomarker monitoring. And indeed, home blood pressure monitors, we're going to talk about that for monitoring blood pressure in those with hypertension, blood glucose monitoring. Fatigue is important, We've already talked about that rating of perceived exertion, never mind physical activity trackers such as accelerometers or pedometers. Important to remember, in this population, exercise time will be reduced, cardiorespiratory fitness is reduced, and muscle fitness is reduced. So we have to start low and go slow. And then a very important principle in creating a time-efficient exercise prescription, because if you go back to the physical activity guidelines for Americans, how many hours a week are we asking people to exercise in a population where 70% will not achieve those recommendations? The key is multi-component exercise, meaning that there are exercises out there where you can wrap all into one: aerobic, resistance, flexibility, and balance, and reduce total time. And at the top of the list, I can think of a great example is yoga, video games, and circuit weight training would be right at the top of the list. Contact and high risk sports are not recommended in this population. We've already talked about starting low and going slow. Again, total time is an issue and a deterrent. So because of the low fitness level in this population, you can actually consider the warm up and cool down to be part of the exercise session. Doing something is better than nothing. The heat map, all movement counts and it adds up. And the long-term goal, which many people won't achieve, is that ACSM Fit principle for healthy adults, or the physical activity guidelines for Americans. So let's move on with an emphasis for cardiovascular health. And the comorbidities I would like to focus on in the remainder of my presentation are pre to established diabetes, dyslipidemia, hypertension, anxiety, and depression. So I am not going to read through this. It's very similar format to what you saw for the FITT exercise prescription for people with HIV. In this case, it is the ACSM recommendation for diabetes. And for this population, the focus would be on those with type 2 diabetes. And if you look at this time recommendation, what's it very familiar to? The physical activity recommendations for Americans. But you can read the nuances because you will have access to my slides, and Deanie will post those with the YouTube video of the tape recording. But important things to remember for this population: blood glucose monitoring. First of all, in particular, if blood glucose is unstable, but something that actually is getting increased attention, especially due to the lack of exercise adherence. And it was actually a nurse from Yale University. Her last name was Allen. She published 3 studies in around 2009, where she monitored the blood glucose of her patients with diabetes before and after exercise. And guess what? They saw their blood glucose improve, and it was a major motivator to exercise. If peripheral neuropathy is evident, proper foot care becomes important, and you might have to emphasize non-weight bearing exercise. If autonomic neuropathy is evident, heart rate will not work to monitor the exercise intensity, and you will have to resort to perceived exertion or the talk test. 2 very important take-home messages here about multi-component exercise, and an important take-home message from my presentation today. Resistance exercise confers similar cardiometabolic benefits to aerobic exercise. And more importantly, when you combine them, they may work better and reduce exercise time. Let's move on to dyslipidemia. And I will say, without going into the nuances of the ACSM Fit for dyslipidemia, the recommendations here on paper are very similar to those for physical activity guidelines of Americans. But if you delve into the literature, the prescription varies based on the component of the blood lipid profile. And so I won't read through these, but these are the various abnormal values for the component of the lipid profile that would classify someone as having dyslipidemia. Medical management, and this is why this is italicized, is on LDL lipoprotein, and that's how people are medically managed. And you can see that aerobic exercise lowers LDL 3 to 6 milligrams per deciliter. Very high volumes of exercise are needed, so you know, to raise HDL and lower triglycerides. Some of the good news I have to share with you is that resistant exercise appears to reduce LDL and triglyceride levels more than aerobic exercise does. And that's not in that ACSM Fit I shared with you. So again, here we see this combined exercise modality of aerobic and resistance exercise appears to be most prudent because in adults with dyslipidemia, it can improve HDL, triglycerides, and LDL simultaneously. This is the FIT for hypertension. Once again, I'm not going to read through the specifics, but I want to point something out. Notice aerobic and or resistance. Again, combined modalities is being recommended here. And our lab has made a statement that we would add an and or here with neuromotor. So all three modalities lower blood pressure. And what I'd like to point out to you about the summary here, if you have hypertension, you are recommended to exercise on most, preferably all days of the week. And do you know why that would be the case? Your blood pressure is lower on the days you exercise than when the days you don't. And that's acute exercise effects. We also saw it with blood glucose. Very important concept we're going to elaborate on. Just to remind you, this is the definition of hypertension. Medications become very, very important again, particularly beta blockers and calcium channel blockers and alpha blockers. We said all three of these modalities lower exercise. Any intensity works, low, moderate, or vigorous. Important to keep in mind, regular monitoring with a home BP monitor, especially before and after exercise, because, and this has been a focus of the work in my laboratory for many years, your blood pressure is lower after you exercise than before for up to 24 hours, termed post-exercise hypotension, and it clearly can be used, and we have a publication on this, as a behavioral strategy to increase exercise adherence. Moving on to anxiety, again, the importance of medication. Note, aerobic resistance and neuromotor all reduce symptoms. With clinical populations, aerobic may work better. High intensity aerobic exercise may have greater effects on decreasing anxiety than lower intensity. Notice we're back to the acute effects. They're immediate. But for optimal effects, exercise program needs to last. And again, that focus on exercise adherence. One thing you should be aware of, those with panic disorders experience many of the same symptoms we experience when we start to exercise, increased heart rate, shortness of breath. So they should be educated to this as such. And notice there could be a reduced sensitivity to rewards that present challenges for exercise adherence. And last will be depression. They all work again. So one other thing I would like to suggest, if someone hates aerobic exercise, then they can do resistance or neuromotor. So again, getting back to that exercise adherence challenge. Medications are important. Any intensity works. You see acute effects here, just like with hypertension, blood glucose, anxiety, but the exercise program needs to last. So again, challenges with exercise adherence may be improved with emphasis on self-regulation of biomarkers. So I will now conclude my presentation with a couple of closing concepts and remarks that from a public health perspective, total volume of exercise is what matters for health. So you can always substitute frequency and time for intensity. All movement counts and it adds up. Doing something is better than doing nothing. Start low and go slow. Devising creative strategies to reduce the time of exercise while maximizing health benefits, those multi-component types of exercise, and using behavioral strategies and theories to improve adherence. And I would say something that's emerging in our field is the self-regulation of biomarkers to increase exercise adherence. And as always, with your team, practicing good clinical judgment. So I leave you with additional references that I highlight from some of the material I presented today. And I would now conclude my comments and open up remarks to Dr. Berry. And so you know, this is a Tai Chi study we did at Seabury and Bloomfield. Thank you.
That was terrific. Thank you so much, Dr. Pescatello.
You're welcome.
Years ago, I went over to Dr. Pescatello's lab, and she put me through my paces when I was starting up a research program on chronic pain and opioid use disorder. And, chances are that if you haven't had low back pain already, you're going to get it, right? With our long lifespans in the United States. And one of the key recommendations of the American College of Physicians is to stay active. Right? That if you want to manage back pain, stay active. And I kind of thought, that's a really interesting idea, right? That it could convince the people I was working with who had pain and opioid use disorder to stay active. And in part because many of them have the fear that if they move, they're going to injure themselves. So reading over Dr. Pescatello's work, part of what I've tried to do over the years is in some ways not to let the perfect get in the way of the good. Start where the patients are at, that many of the patients I work with don't exercise. They're highly sedentary. I try and normalize it, given what Dr. Pescatello said about, it's not just patients with HIV or substance use disorders who don't exercise, it's all of us. And then what can we then practically recommend? And what we've tried, for example, at the App Foundation are things like having people go out and walk, so walking groups. We've tried out FITT groups. We've tried out yoga. We've tried out Tai Chi. And what's kind of interesting about these groups in some ways is that they don't involve talking. And there are quite a few people, I think, probably both with HIV and with substance use disorders, who are maybe fed up going to counselors or going to groups where the emphasis is on opening up. There's something kind of normalizing and very democratic, from my point of view, about physical activity. It affects all of us. We're all getting older. It affects how well we age as we get older. It's related to not only common physical health concerns, but also the common colds of psychiatric problems like anxiety and depression. So we all have skin in the game. And over the years, I've turned to Dr. Pescatello's work and people like her to try and figure out, well, what is it that those of us who are not specialists can do? And I think what those of us who are not kinesiologists, what we can do is at least start bringing attention to our patients about how much are you exercising? What might be the benefits of exercising? You're not currently exercising, how about you do it for a minute? Oh, you feel lonely when you exercise? How about you bring your dog out with you? Right, that there's all sorts of avenues that exercise can be incorporated into to promote lifestyle change. And Dr. Pescatello has been a terrific researcher, not just in terms of finding out the health benefits and the science behind exercise, but how they can be applied to those of us who aren't all that motivated to begin with? And how do you get people like me to do it, not just once, but do it day in, day out, and come up with a lifestyle change? I think some of the things that are going to face us, maybe as a field going forward, might be things like who's going to pay for it?
Mhm.
Also, providers, from my point of view, are often not trained to do it or don't feel comfortable talking about exercise, especially with people who maybe have limitations. And how do we maybe overcome that? But I think Dr. Pescatello is a terrific resource as we try and figure out these kinds of questions. And Dr. Edelman, thank you so much for inviting me to talk. It's an honor to speak after Dr. Pescatello.
Thank you, Dr. Berry, and thank you, Dr. Pescatello, for just a fabulous talk. There was one question in the chat that I think wasn't addressed, and that was by Sam, and he was asking about how does standing fit in? If you're standing, how does that calculate into the sitting time? Does standing help offset even if you're not actually moving? So maybe we can, Dr. Pescatello, do you mind addressing that? And then I think there's some other questions we can bring up.
Yeah, sedentary behavior and is defined as 1.5 METs or less during the awake hours. And so standing, I know, is coming to vogue in front of your desk and things like that. It's better than sitting, but if your choice is to stand 2 hours a day, and we look at that curve, you're not going to see that huge reduction in risk that we saw of getting out of the chair and walking across the room. So in terms of accumulation, you would be expending a few more calories than when you're sitting, but you wouldn't on that curve see those reductions in risk we were talking about.
Thank you. And Dr. Justice, I know you had a question. I don't know if you want to articulate it about how do we improve adherence to physical activity beyond using glucose monitoring and other biomarkers. Was that your question?
Yeah, that's right.
Yeah.
Well, in our studies, and in fact, we went through extensive training of the kinesiology GAs, where they were trained in contingency management and motivational interviewing. And we use those strategies because, again, back then, wearables were just coming onto the market. We used, with the college students, we used accelerometers to measure physical activity. We did not do that with the clinical population. And I've talked to Declan about this with the study we're going to start, because sometimes they walk and they're not cheap. I mean, they walk away themselves and it's around $400. So we use different methods. And that's the other thing I would strongly advise in these studies. Do not measure physical activity just one way. Measure it in multiple ways, both subjectively and objectively. Very, very important. But we integrated behavioral theories and strategies, which quite frankly, most of you are much more expert in than I am. And that's the value of the team. But also the kinesiology GAs, I forgot to mention this. We mandated verification of exercise. So they had to show us some proof that they did it. And then the kinesiology GAs checked in with the participants on a regular basis. And it's an integrated model that you're all familiar with, that we used.
Thank you.
Well, this has been such a wonderful, rich discussion. I wish we had another 4 hours, but I recognize it's 3:01, so I want to be respectful of everybody's time. Dr. Pescatello, Dr. Berry, thank you so much. Deanie and Pete, thank you for organizing, and really just a wonderful discussion and presentation. Thank you so much.
My pleasure. Thank you, everybody.
Thank you, everyone. Have a wonderful holiday season.